Good morning, everyone. My name is Tia Smith,
Emery McIntyre.
and today we'll be presenting on Osteitis pubis, or also known as athletic pubalgia. Some of our objectives today are to define the pathology, determine the pathomechanics that lead to this pathology, learn about the clinical manifestations and functional limitations, establish tests and measures to determine the pathologies, differentiate between different diagnoses, discover the rehab phases and interventions, and then ascertain the probable outcomes of rehab interventions for these pathologies. So osteitis pubis, what is it? It's an activity-related abdominal and proximal adductor-related pain that occurs in those who perform activities that create continual shearing forces at the pubic symphysis, such as unilateral leg support or acceleration and deceleration forces required during multi-directional activities like runners, basketball players, tennis players, and gymnasts.
So getting into the pathomechanics, kind of broke it up in two different parts here. So osteitis pubis, often caused by, as Tia said, an irregular force across the pubic symphysis. This can be due to things such as muscle imbalance, poor flexibility, SI joint dysfunction, leg length discrepancies, excessive pronation, and varus/valgus deformities. Then the athletic pubalgia portion consists of a chronic stress injury that affects the lower abdomen and groin, including chronic stress injuries with bone inflammation, and other factors that can contribute to this are limited motion in the lower kinetic chain, hyperabduction of the hip, and trunk hyperextension. So it's also classified by some abnormal biomechanical forces. So it's an opposing forces of the rectus abdominis and the adductor longus muscles on the pubic bone, and repetitive use of these muscles can lead to chronic tendinosis and some instability of the pubic symphysis. So after repetitive use, it becomes abnormal, which can lead to pubic bone stress reactions, degeneration of the hyaline cartilage, and some symphyseal instability. So age is also a factor, as this condition usually appears during the 3rd and 4th decades of life, and it is more often in men. And there are 4 stages of progression. So in the first stage, it's characterized by unilateral symptoms. For example, pain in the adductor muscles when kicking a soccer ball. This pain goes away after warming up but comes back after training. So the second stage, characterized by bilateral inguinal pain. This pain worsens a lot after training. So stage 3, characterized by bilateral inguinal and lower abdominal muscle pain. This pain also worsens with movements such as kicking, sprinting, changing direction, long walks, and transitioning from sitting to standing. And our 4th stage, the bilateral inguinal, lower abdominal, and low back pain. And this pain level worsens with activities such as defecation, sneezing, walks, and even prevents individuals from performing regular ADLs. So our clinical manifestations, we have pain, tenderness, hip issues, edema, and muscle spasms. So our pain is going to be located in the groin and lower abdominal region, and it can feel as either a dull ache or a sharp pain. We have tenderness along the pubic symphysis and adductor muscles. Our hip issues include decreased hip rotation, pelvic misalignment, or sacroiliac dysfunction. We have edema, which is just swelling or tightness in the pelvis. And we also have muscle spasms, which occur in the adductor region. Our functional limitations include difficulty walking, clicking and popping, or pain with movement. So difficulty walking, you'll see things such as ataxia gait, waddling gait, and just some overall weakness. Some clicking and popping, you'll see in movements such as flexion or extension. For example, when you're sitting and rising from a seated position. You'll also see it in movements such as turning over in the bed or walking on uneven ground. And some pain with movement, you'll see this when an individual is coughing, sneezing, or walking on
assess and measures, you can perform a palpation examination by palpating the pubic tubercle or pubic symphysis. You could also have the patient perform a resisted sit-up with palpation of the inferolateral edge of the distal rectus abdominis, which could produce symptoms. For another test you could do is the Faber test, and you could also look at their range of motion, and with this condition, range of motion in one or both hips could be limited, and as far as imaging goes, you could use an MRI or do film imaging. So for differential diagnosis, I had two different pathologies. So the first one is spondylar arthropathy, and the other one is symphysis pubic dysfunction. So spondylar arthropathy is an inflammatory arthritic condition that may manifest with pain associated with stiffness. When compared to osteitis pubis, spondylar arthropathies are asymmetrical, include bowel and optical problems, and have extra-articular involvement, whereas osteitis pubis, when grade 2 or above, has bilateral involvement of the lower extremities, no bowel involvement, and no bowel involvement. In fact, swimming is one of the recommended exercises for rehab, and as we know from physical agents, it would be contraindicated if one has gastrointestinal problems. For symphysis pubic dysfunction, is defined by stretching of the ligaments between the pubic symphysis, and while osteitis pubis is more prevalent in men. So symphysis pubic dysfunction is more prevalent in pregnant women, whereas osteitis pubis is more prevalent in men. Additionally, the areas of pain differ, where SPD pain is more on the thigh. Osteitis pubis is around the inguinal ligament at the groin or proximal thigh. Additionally, for symphysis pubic dysfunction, it's a lot more ligamentous pain, or the ligaments cause the pain, whereas osteitis pubis is more muscle, tendon, or fascia overuse. And then pain is provoked by placing bilateral pressure on trochanter or hip flexion with legs extended for symphysis pubic dysfunction. But for osteitis pubis, it occurs by having the patient squeeze a fist between knees with resisted adductor contraction and knee flexion and extension. So for the rehab overview, the goals are to increase mobility, strength, elasticity, and stability. You want to avoid, during conservative treatment, deep hip flexion and low reps, and also heavy weight strengthening. Some of the conservative treatment occurs in 2 phases. Phase 1, you want to do static exercises, sit-ups, a sit-up and hip flexion, combined balance exercises, and 1-foot dynamic balance exercises. Phase 2, you want to do leg abduction, adduction, prone low back extensions, weighted single leg abduction and adduction, sit-ups, single leg coordination, and dynamic stability. If none of those work, you have recalcitrant patients, which is just recalcitrant meaning they are not responding to treatment. You can perform surgery or also do corticosteroid and prolotherapy injections. The probable outcomes of treatment for osteitis pubis during conservative treatment: patients usually return back to normal physical activity within days to weeks. There's a 25% recurrence rate in men, and it's 5 to 10% recalcitrant. Progressive rehab, you can return to sport within 4 to 13 weeks, and surgical interventions, you return to sport in 3 to 4 months, and you have a low recurrence rate. So for the overview, we learned about osteitis pubis, we learned that it affects athletes, we learned about the 4 distinctive symptoms, we learned that the pathology is defined as pain due to shearing forces, we learned about the special tests of imaging, the rehab processes, and the outcomes. Here are our references.